Watch this video, I'd like you to write to your MP or your representative in Parliament or something, because I'm just at a loss at what to do about this. And I think it's really important. I'm going to give evidence that we should be aspirating the needle before we give the injections. Basically, I think that most people in the UK and the United States are giving the vaccine injections wrongly. Now, what you should do when you stick a needle into a muscle, because it has to be an intramuscular injection, so the needle's not that quite big on the vaccine, but you stick it in, then you should hold it like that. And then what I always do is I draw back, and if you draw back blood, you know you're in a vessel, so you would pull it out and change the needle and get a different site. But that's not being done. Now, if that's not done, let me show you what can happen. So this is what can happen. So imagine you're giving the needle, you stick it into the muscle, and for just pure misfortune, you find you end up in a blood vessel. Then if you draw back and you're in the muscle, then no blood will come out. But if you're in a blood vessel, then you draw back and there you go. You know straight away you're in a blood vessel, and you know not to inject it, because you would then be giving this intravenously. That would be going straight into a vein, not into the muscle where it is supposed to go. So we're doing this wrong. Now, I'm going to be giving evidence for this today, and this really has to change. So I'm going to give evidence from this paper here. Now, do look at it for yourself. I always post the links, of course. Now, this is the name of the title here, intravenous injection of coronavirus disease. Now, this is with messenger RNA vaccines. Can cause acute myopericarditis. So myocardium, the middle layer of the heart, pericardium, the outer layer of the heart, and itis on the end means inflammation of, because we know it can cause this heart inflammation. Now, this is from the Clinical Infectious Diseases. They describe it as major article, peer-reviewed, published with the auspices of the Infectious Disease Society of America, HIV Medicine Association, Oxford University, and Oxford Academic Publishing. So, I mean, basically, what more do people want to start listening to this? It's just unbelievable that this is still being done. And in my view, disgraceful. Now, let's get to the evidence, the background to this. Post-vaccination myocarditis and pericarditis reported after coronavirus mRNA vaccinations. And we also know that after the adenovirus vector vaccines, there's been this thrombosis, thromboembolism problem. And I believe that some of these cases have got the same origin. That is the inadvertent intravascular administration, because people aren't drawing back. Now, I'm going to give the evidence for it. So, the effects of accidental intravenous injection of this vaccine on the heart is unknown. Direct quote from the authors of this peer-reviewed published paper. Now, this study is done in mice. Now, to be fair, okay, mice aren't ideal, but you couldn't very well do this in humans. You couldn't line a load of people up and give a load of people the injection intramuscularly, checking it was intramuscular by drawing back first and rolling the sleeve up in another bunch of people and giving it directly into a vein in the arm. That would be completely unethical to do in humans. I mean, a lot of people don't like doing it in mice, but this has been done in mice. So this is just new research published. So it's done in mice, comparing the difference between intramuscular and intravenous injection of vaccine. And they looked at clinical manifestations in the mice. Histopathological changes. Now, of course, histo is the study of tissues. Pathology is the study of disease. So this is disease changes in the tissues, and they looked at that under microscopes and did lots of studies on that. They looked at tissue messenger RNA expression to see if the spike protein was being expressed in the tissues of the body when you don't want it to be. They looked at serum levels of cytokines, and troponins are released by damaged heart muscle, indicating heart damage. So they looked at that, and they did it really well, because they did some intravenous, some intramuscular with the vaccine, some intravenous, some intramuscular with normal saline as a control. This is a very well conducted experiment. Now, what did they find out? Intravenous SARS coronavirus 2 mRNA vaccine administration induced grossly visible pathology in the heart. There you go. Now, if you want to look at this article, it's all there. You can download the PDF. It's completely free, which is good of the Clinical Infectious Diseases Journal to do this. And it shows you the actual pathological pictures of the organs from the mouse with the microscope slides and all the immunostaining and all the clever stuff they did. It's a really impressive piece of work. So yes, giving mice SARS coronavirus 2 messenger RNA vaccines caused grossly visible pathology in the heart. It did, but only in the IV group. They're the only group that developed the histopathological changes of myopericarditis. In other words, the myocardium became inflamed, the pericardium became inflamed. So the IV group developed these changes in the heart. The intramuscular group didn't. And of course here the intravenous group were given the intravenous injection quite deliberately, but I'm saying that 1 in every few thousand could probably be given inadvertently intravenously in the vaccination campaign that we currently have. And this really has to change. It's simply not good enough. How can governments be so blind and educators be so blind as to not see this? Here's the evidence. There is evidence of cardiomyocyte. Now, the cardiomyocyte, so the actual myo is muscle. Cyte, of course, is cell. So the cardiomyocytes, so the actual cells of the heart muscle itself, the actual contractile muscular cells of the myocardium. So the evidence was in there, and there was a degeneration of those tissues. So there you go. That's what they saw. They saw it with a microscope. They saw it with their eyes. They saw it in all the tests. You know, the evidence is there. If it's given IV, intramuscularly, no problem. No problem. They also found apoptosis of the myocardium. Now, apoptosis is a mechanism whereby cells actually commit suicide. And the cells die and you develop an area of necrosis. You actually get dead cells. Necrosis with adjacent inflammatory cell infiltration. So the apoptosis caused the necrosis. That caused the inflammation, and inflammatory cells infiltrated into that area. And as well as that, there was calcific, that's calcium-based deposits on the visceral pericardium. So there's two parts of the pericardium. There's the visceral and the parietal. The visceral is the inner part, the parietal part's the outer part of the pericardium. And there was calcium deposits. Now, what the calcium deposits usually mean is when a tissue is damaged, it can become calcified. So this indicates that there was damage to the pericardium, which then resulted in calcification. And of course, you don't want a calcified pericardium because the contractile heart is inside the pericardium. So the last thing you want is a rigid, sort of bony almost pericardium. That would be a very bad thing. That will cause a condition called constrictive pericarditis. So there you go. Those changes are there in mice. If you gave the vaccine intravenously, they were there. If you gave the vaccine intramuscularly, they were not there. It really doesn't get any simpler than this. Evidence of coronary artery or other cardiac pathologies was absent. So this is not a disease of the coronary arteries, which is the common disease. The coronary artery atherosclerosis, which is the common furring up disease of the arteries, was not present. Spike antigen was recognised by immune staining, occasionally found in infiltrated immune cells of the heart. So the actual pattern of the spike protein was seen in the immune cells, and the spike protein had actually been expressed by the cardiomyocytes. I'll do that bit first, by the cardiomyocytes. So what this means is, because the vaccine was given intravenously, the RNA to make the spike protein went into the blood. It got into the myocardial cells. The spike protein RNA went into the myocardial cells. The myocardial cells produced the spike protein, expressed that to their cell surface. And of course, that's a foreign protein. So the body's immune cells said, oh, foreign protein there. And they attacked it, and they attacked the cell. And that's what caused the inflammation of the myocytes in the myocardium. All this should be happening and just giving you a bit of a sore arm, not a sore heart. If it's given in the muscle, if it's given intravenously, it goes to the heart. And as we'll see in a minute, it goes to the liver as well. And it was also in the intracardiac vascular endothelial cells. So what you have in the heart, you have various blood vessels, of course. So imagine that's a bit of a coronary artery there. And that's going to divide into smaller branches. And all these blood vessels are lined with the vascular endothelium to make it nice and smooth for the blood to go through. So what this is saying that there was inflammation of the intracardiac vascular endothelial cells of these blood vessels. So because there's damage to these blood vessels, that gives the inside of these blood vessels, that gives rise to the possibility of blood clots forming in there as well. Now, I didn't say that, but that gives rise to that possibility. But anyway, you don't want it to be inflamed. The histological changes of myopericarditis after the first IV priming dose persisted for 2 weeks. So there was For 2 weeks, they found evidence in the mice that they examined that this damage was there 2 weeks after the first priming dose, but were markedly aggravated by a second intramuscular or IV dose. So, in other words, if the first dose was given IV inadvertently, even if the second dose was given correctly, that still aggravated the condition. And of course, this is exactly what we are seeing. There is more myopericarditis after the booster dose than after the first dose. It is exactly what we're seeing, and this has been exactly duplicated in this study. We need to change the policy. Numerous inflammatory cytokines found in cardiac tissue. The cytokines are the messengers. Cyto is cell, kainos, kines, movement. So these are chemicals that communicate between cells and generate inflammation. So there's one called interleukin 1 beta, which causes inflammation. Another one called interferon beta, another one called interleukin 6, and another one called tumor necrosis factor alpha. Now they're all released by the cells, and they all lead to inflammation. And you don't want an inflamed heart. But this was in the intravenous group, not in the intramuscular group. This is only if this was given intravenously. Compatible with the presence of myopericarditis in the intravenous group, just to spell it out, they said it twice. And they also saw ballooning, enlargement, degeneration of hepatocytes. Now, hepatocytes are in the liver. Now, we don't know of liver problems caused in humans, but it was noticed in the mice, so it could happen in humans as well. And also found in the IV group, not in the intramuscular group. All other organs appeared to be normal, which of course is exactly what we are seeing in humans after the mRNA vaccines. This is exactly what we're seeing. So what conclusions did they draw from this paper? This is in vivo evidence, in life evidence, that inadvertent intravenous injection of COVID-19 messenger ribonucleic acid vaccine may induce myopericarditis. There you go. I mean, it can't be any clearer. Brief withdrawal of syringe plunger to exclude blood aspiration may be one possible way to reduce such risk. Direct quote from the authors. Both Pfizer, BioNTech and Moderna have clearly stated that their vaccine should only be given via the intramuscular route, not the intravenous route. So why on earth are we not ensuring that the manufacturer's recommendations are obeyed? And it's done according to the manufacturer's guidelines, rather than giving the occasional intravenous injection by mistake. It's just completely unacceptable. Current CDC and WHO guidelines no longer recommend precautionary measures during the intramuscular vaccine administration. And I could add that the Green Book in the UK doesn't recommend it either. I'm not making this up. This is the CDC, the WHO, and the Green Book, the official government bodies that control vaccination in the United Kingdom, are saying, don't do your injections properly. Don't aspirate. They actually say, don't aspirate. It's unbelievable. This is just beyond my ability to comprehend, I'm afraid. Direct quote from the article, the CDC Pink Book 2020 and the WHO 2015 position paper have recommended against aspiration prior to vaccination so as to minimise pain. Is there a rationale for that? I think that is completely, utterly wrong. Now, this article also said that, of course, we're giving the vaccine into the deltoid muscle up here. But from the deltoid muscle into the lymphatics under the axillary lymph nodes there's a pretty direct communication from there. Whereas if you give it into the vastus lateralis muscle, that's the thigh muscle up there, into that thigh muscle, and it's got to go through quite a lot more lymphatics to get into the blood. So they think that giving it into the vastus lateralis, into the upper outer aspect of the thigh, might be better. They're not sure about that, but they say that's a possibility. So worth considering. Our study indicates that intravenous injection of the vaccine might partly contribute to this clinical phenotype. So they're being very cautious. Clinical phenotype means what's going wrong with the heart and the liver, thus warranting a reconsideration of the practice of intramuscular injection without aspiration. Again, they're putting this very Clinically, but that's a direct quote from the paper. If it's in italics, it's a direct quote, which carries an inadvertent risk of intravenous injection. So there we go. Case proved in mice. And of course, mice are mammals exactly the same as we are. We really need to change this practice. Now, in terms of the adenovirus vector vaccines, the Janssen, Johnson & Johnson, the Oxford AstraZeneca, we've looked at this in detail before, but the same is true. It should be given intramuscularly, not intravenous. Now, what we've looked at before from this paper, we looked at this in some detail about 6 weeks ago, I think it was now. But again, it's all there. Download the PDF, check it out for yourself, make sure I'm not making it up. Thrombocytopenia. So the thrombocytopenia, of course, you remember, is the low levels of thrombocytes in the blood. In mice reported in 2006. This has been known since 2006, published in the journal Blood. All mice received virus through a single tail vein injection. Thrombocytopenia has been consistently reported following the administration of adenoviral gene transfer vectors, if it's intravenous. So in other words, the complications, or some of the complications that we're seeing from the adenovirus vector vaccines in terms of thrombocytopenia and thrombosis could also be caused by inadvertent intravenous administration. Now, I started this by saying, can you write to your MP or something? Because I've tried, and I'm just at my wit's end with this. I really don't know where to take it next. So I've got this letter. This letter here is from my MP. Kindly passed it on. Dear John, writing back to me, thank you for your correspondence, etc. Has passed it on to various people. And anyway, this letter ended up with Nadeem Zahawi, the vaccine minister. That's where it ended up. And he basically says, I've nothing to worry about. So here we go. From the reports of major thrombosis and concurrent thrombocytopenia, and this was back in the day talking about the this is when I first wrote in about the adenovirus vector vaccines, but we now know the same is true for the messenger RNA vaccines. We've not been able to identify any evidence of association with errors in administration in the UK cases. Well, of course you're not, because if you get it wrong, you don't know, because you stick the needle in, you inject it, and you pull the needle out, and you haven't got a clue. Let me say that again. You haven't got a clue whether it's gone into a muscle or a vein. So, of course, you don't know if you've got it wrong. It's not as if you say, oops, got that one wrong, better go and report that. No, you would simply never know. So this is just poppycock, what Nadeem Zahawi's person has written here. It's just... The very rare clotting condition reported following the administration of the University of Oxford AstraZeneca vaccine is thought to be due to an immunological mechanism rather than the way in which the vaccine is given. That's their opinion. But they don't give any evidence for that. I think part of it's due to the intravenous administration. Guidelines published from Public Health England states there is no need to pull back on the plunger, aspirate before the plunger is depressed to release the vaccine into the muscle. Well, hopefully into the muscle, because there are no large blood vessels at the recommended injection site. Now, this just beggars credulity. Let me just tell you what they've said here. Basically, they've said that this muscle, there's no blood vessels going to this muscle. It doesn't have a blood supply. Now, if you get an elastic band and tie it around your finger and cut off the blood supply, it'll go red, it'll go white, then red, then it'll go mottled, then it'll go purple, then after a few days it'll turn black, and then it'll drop off. It'll die. It's called necrosis. You know, the idea that a minister of the realm is writing to me saying that there's no significant blood vessels in a muscle. It's just unbelievable. A muscle is a living tissue, therefore it's got a good blood supply. I mean, why don't these people realise that? You understand this, and most of you aren't clinicians. You know, why don't they get this? It's just don't want that one. That one. There we go. Right. Well, anyway, the rest of it's just blur. But anyway, so basically, I'm not knocking Nadeem Zahawi. He's just a politician. But he should be advised. Well, I am really, because we need more doctors and scientists as politicians. I don't know what Mr. Zahawi is before he was a politician. He might have been. I'm pretty sure he wasn't a doctor or a scientist. But there you go. People, politicians that were doctors and scientists tend to understand this stuff. But there's very few of them. So there we go. I understand it now. You understand it now, but our governments don't. If you can think of something to do, please do, because, I mean, Why don't we do it properly? Right. Anything you can think of to rectify the situation. The references are there in the description. If you know anyone in power, get them to change the policy. So we stick the needle in, draw back. If there's no blood, then we inject, keeping the needle in exactly the same position. So you stick it in, you hold it where it is so the needle's not going forward or back. You aspirate. If there's no blood, then you inject it with the needle not going forward or back. And what I do is I'll just stick the needle in like that. I'll stick it in, and then I'll hold my fingers just against the patient's skin to keep it in just the right position. And I've taught student nurses to do that using that exact technique for well over 30 years. And now the CDC, WHO and Public Health England say you don't need to bother doing it. If you can think of anything, please do. Thank you for listening.